Hi, everybody. Welcome back. We are in week 13, module 13. I'm so happy that we got this far so far. We're doing fantastic. Everybody's getting through it. I'm so proud of you. This week, we're going to talk about psychosocial problems, the second part. We went into the first part last week. This week, we're going to focus on behavioral disorders related to physical and physiological disturbances, neurodevelopmental disorders, the 15-minute hour practical approach to behavioral health for primary care. And we're going to review the APRN practice guidelines from your readings. I wanted to just do a focus review on a few things that I wanted to make sure you pay attention to in terms of your guidelines. Just a review of last week's topics. In Module 12, we reviewed common psychosocial complaints. We discussed the DSM-5 manual, which lists and references and defines all the diagnostic criteria for mental disorders, which is really important for you to be aware of, as this manual is referenced frequently throughout the psychiatric world. So you're always going to hear about the DSM-5. Just make sure you understand that it is a diagnostic and statistical manual of mental disorders. We reviewed depression, symptoms of major depression, depressive disorder, including the diagnostic criteria of 5 symptoms or more, being present for at least 2 weeks, causing difficulty in functioning in order to diagnose it as a major depressive disorder. We reviewed intimate partner violence, IPV, and discussed the CD recommendations for prevention and how to prevent it. We reviewed substance use disorder, including the diagnostic criteria of mild, moderate, or severe, depending on how many symptoms they're exhibiting. We also discussed overdose and the appropriate medications for overdose, withdrawal, and addiction. We reviewed schizophrenia spectrum disorders and focused on clinical features and psychosocial treatments. We also reviewed bipolar disorder and related disorders, including bipolar versus unipolar depression. And most importantly, we reviewed this warning signs of suicide and specifically focused on our high-risk populations, such as the veterans and the elderly. And we also discussed the new National Institute of Health Suicide Prevention Resources and the Prevention Crisis Lifeline that you do have access to, that you want to make sure you know where to get resources from in terms of that website, so you can always have it readily available within your practice and for your patients that need it. We talked about anxiety, stress, and trauma-related disorders. And we definitely got into obsessive compulsive disorders with a focus on the first line treatments of OCD, including cognitive behavioral therapy and medications such as fluoxetine, sertraline, escitalopram, and paroxetine as all options for treating OCD. In this week, we're focusing on chapter 70, which is eating disorders and sleep-wake disorders, such as insomnia and restless leg syndrome. We're going to talk about neurodevelopmental disorders, including autism spectrum disorder, intellectual disability, tic disorders, and ADHD. We're also going to get into what they call the 15-minute hour, which is basically just practical approaches for any practitioner, specifically practitioners that work in primary health, to assess the patients with any kind of psychiatric problems going on. And then we're going to just go quickly through the APRN guidelines that we had you do in your readings. I just wanted to pinpoint a few things to make sure you're paying attention to certain key things in those guidelines. So in terms of the guidelines, this last 2 modules, we focused on anxiety, ADHD, bipolar, depression, failure to thrive, grief, sleep disorders, and suicide. So those were the ones you needed to review. In terms of anxiety, I just wanted to make sure you realize it includes common complaints such as the inability to control worrying, motor tension, sleep disturbances, and autonomic hyperactivity vigilance, which means they want to keep going, want to keep doing things, got to keep going, got to keep moving, got to keep moving. That's the kind of thing you see with anxiety. Make sure if the patient reports to you that they are self-medicating with alcohol to help with sleep, this may indicate a coexistent alcohol abuse dependence diagnosis that you're also going to want to make sure you treat and definitely deal and talk to with the patient. And this self-medication, it not only goes with anxiety, it can go with any of the psychological things. This I'm sorry, the behaviors, the psychological behaviors, disturbances that we're talking about. Anybody who's self-medicating with alcohol in combination, we definitely want to screen them for alcoholism and get their treatment in place. In ADHD, I wanted to point out to you that the criteria to diagnose ADHD is actually listed right on the CDC website. So please review that. The website is right here in terms of diagnostic criteria. And also keep in mind, up to 50% of patients with ADHD have other psychosocial disorders. That's the word I was looking for, psychosocial. Bipolar disorder, also known as manic depressive disorder. Remember, it is a chronic disorder that will require long-term continuous treatment for the remainder of the patient's life. So make sure that you don't leave it untreated, because episodes of mania and depression may become more severe and more difficult to treat over time if it is left untreated. Keep in mind, treatment with medication in terms of lithium requires frequent lab workup prior to initiating it, and then you need to have lithium levels drawn 2 times per week until the target serum levels are reached. So just make sure you keep that in mind in terms of treating bipolar disorder. In terms of depression, please review table 22.1 on page 779 for common antidepressant drugs that we prescribe in terms of dosages. We reviewed failure to thrive. Most patients do not present with failure to thrive. It's usually diagnosed on routine examination, either in the ambulatory setting or specifically also in the long-term care setting. In terms of failure to thrive, in your practice, you want to make sure you're noting and documenting any changes in their growth curve. That's more specifically for your pediatric patients, but in terms of your elderly, you're going to be documenting weight and labs, okay, just to make sure you're showing any either decline or improvement. In terms of grief, we reviewed the 5 stages of grief: denial, anger, bargaining, depression, and acceptance, Kubler-Ross. That's important to know your stages of grief so that you're very clear on differentiating normal grief reaction versus major depression. You want to make sure you understand the bereaved's history to understand the loss. So why is the patient grieving? Focus on the patient's history. What happened? What are they grieving for? So that you can really get a sense of the level of loss that they are dealing with. In terms of sleep disorders and insomnia, keep in mind the risk of depression increases with time if insomnia is left untreated. So you want to make sure you're screening these patients periodically for depression and suicide risk, of course. Do not prescribe meds for sleep to clients with alcohol, drug, or depressive disorders. We don't want to be prescribing meds for them. They already have, substance abuse issues, and the types of medications we're prescribing for insomnia or any type of sleep disorder, it can lead to further issues, especially in combination with alcohol or drugs. If the insomnia continues for more than 1 month, you are going to want to refer this patient to a sleep specialist. Okay, in terms of suicide, remember your SAD personas acronym that stands for sex, age, depression, previous attempts, ethanol abuse, rational thinking loss, social support loss, organized plan, no spouse, availability of lethal means, and sickness. That is your acronym for SAD personas. This is a helpful screening acronym just to help guide you in screening patients for suicide risk. Remember, any mention of dying or ending one's life must be taken seriously. So please make sure if a patient says that to you, you do not brush it off. You really make sure you go through the screening protocol and document appropriately and give them the resources that they need, as well as their family members, to make sure they have all kinds of help and support in place. Every depressed client must be assessed for suicide risk. Again, document what you said, document the patient's response, document the resources you provided, document who you talked to in terms of family, and any other consultations that you went through for this patient. You want to communicate to all other staff your concerns regarding the patient's suicidal risk as well, okay? Very, very serious, guys. Okay, one other thing I wanted to mention in terms of depression Just keep in mind a few things in terms of depression. Remember, there is a stigmatism on taking medications for depression, especially in our older generation of people. There's a very different paradigm and way of thinking and approaching the use of medication for depression as well as therapy. My dad's way was just kind of buck it up and keep going, Jesse. It was one of those things. So you really have to kind of get through that piece if any of your patients are really coming at you with severe symptoms, because as much as they're acknowledging that they're depressed, a lot of times you're going to get pushback when it comes to discussing the possibility of taking medication to feel better. And that's something you really want to be sensitive to, as well as proactive in terms of just educating the patient on the fact that taking antidepressants can really help turn down the volume and give the patient a different perspective on what normal might feel like, what normal could how normal could improve their life. Sometimes they don't even know what normal feels like. They have forgotten what feeling like without depression and without feeling like this heaviness. They don't remember what that feels like. So sometimes I'll say, listen, you just take it for a short amount of time, just to take the edge off, just to turn the volume down, and just to remind you what healthy, what it feels like to feel normal again. And then they know once they get renewed in that feeling, that sense of normalcy, then they know what to strive for once they stop taking the medication, and how to just ground themselves and find a new foundation for establishing that sense of well-being. So again, in terms of depression, just be very conscientious about talking to your patients and where they're coming from and how they feel about medication for depression, as well as therapy. Okay, getting into behavioral disorders related to physical and physiological disturbances, the first thing we're going to get into is eating disorders. Keep in mind there are 5 types of eating disorders. We have rumination, avoidant food intake, anorexia nervosa, bulimia nervosa, and then binge eating disorders. Okay, anorexia nervosa is characterized by a refusal to maintain a minimally normal body weight and an intense fear of gaining weight due to a body image disturbance. In early adolescence, the patient may also fail to achieve expected weight gain and height gains. There are 2 types of anorexia nervosa: restricting and binge eating purging anorexia nervosa. So with restricting AN, or anorexia nervosa, weight loss is usually accomplished by reducing or restricting all food intake or restricting dietary fat. Versus binge eating purging anorexia nervosa, there is a binge eating followed by self-induced vomiting. So they eat a bunch and then they go and vomit. And then they use also chronic and excessive use of laxatives or diuretics to also help decrease their weight. Providers can expect patients to resist changes in their diet or weight. When you talk to them about it, they're not happy about it. Anorexia nervosa can be accompanied by serious physiological consequences, including amenorrhea, where the women stop getting their period, signs and symptoms of starvation, and of course, electrolyte abnormalities. The next one we have is bulimia nervosa, which is recurrent episodes of binge eating followed by compensatory methods to prevent weight gain and self-evaluation unduly influenced by body shape, which are the 3 essential features of bulimia. So your 3 essential features are preventing weight gain, self-evaluation unduly influenced by body shape, and recurrent episodes of binge eating. Now, keep in mind, binge eating is characterized by eating an excessive amount of food within a 2-hour period. Patients with bulimia nervosa undergo feelings of loss of control during these binging episodes, and then their self-esteem is excessively influenced by their body shape and weight. Compensatory behaviors can include purging, like the self-induced vomiting or misuse of diuretics, laxatives, or enemas, or non-purging behaviors, which is just excessive exercise or fasting. So our purging behaviors are the vomiting, the use of diuretics, laxatives, or enemas, and our non-purging behaviors are the excessive exercise or fasting. In extreme cases, some patients may abuse thyroid hormone replacement medication or try other types of stimulants to help also lose weight. These patients feel an intense shame about their behavior, and they may go to great lengths to keep it secret from others, including healthcare providers. So the one thing in terms of the criteria for binge eating disorder, I just want to reiterate that's frequent binge eating can include eating too quickly until uncomfortable or despite lack of hunger. They get negative feelings that arise or persist from the binge eating, and it's usually not associated with compensatory behaviors. Because if it is, then that would warrant a diagnosis of bulimia nervosa instead. So, in assessing patients with eating disorders, the big thing is focusing on the history, like a lot of things, but specifically in eating disorders. In terms of the assessment components for suspected eating disorders, you want to do your complete history. You want to talk to them about their highest and lowest weight, their goal weight, their dieting history, their daily caloric intake, and the frequency of these behaviors that they're doing. You want to ask them, how often are you throwing up? How often are you stuffing yourself? How often are you taking the laxatives, the diuretics? How often is this happening? And keep in mind, again, a lot of the times they're trying to hide it because they're so shameful that the likelihood is the frequency that they give you may actually be less than what they're actually doing. They may be doing it more than they're actually admitting to. You want to do a complete physical exam. You're checking their height, weight, body mass index, and growth charts. Of course, you're doing vitals, and your laboratory studies should include a CBC electrolytes, a BUN, creatinine, liver function, thyroid function, and your glucose, as well as a urinalysis and electrocardiogram. The clinical factors suggesting the need for hospitalization for these patients would include the presence of orthostatic hypotension, significant bradycardia, syncopal episodes. If these patients are starving, this is what happens. Their heart rate goes down, they start passing out. They would have abnormalities in their EKG, abnormal electrolytes. If they're refusing food for 24 hours, this is also an indication it's time to hospitalize this patient. We have a body weight of less than 85%. They've had no response to outpatient treatment. They have an active suicidal ideation. So any patient, whether they have an eating disorder or not, if they have an active suicidal ideation, they need to be hospitalized. Evidence of psychotic thinking, and of course, active substance abuse or withdrawal. These are all indications that these patients need to be hospitalized. And again, you're documenting what's going on in terms of these criterias, and that will justify the hospitalization. Okay, more psychological behavioral disorders related to physical and physiological disturbances. Here we're going to get into insomnia and restless leg syndrome. Now, insomnia disorder or difficulty sleeping is an extremely common problem, yet it is one that is etiologically complex. It is defined as difficulty in falling asleep or staying asleep, waking up too early in the morning, or any combination of these. I'm sure all of us have experienced insomnia at some point, especially with all the stress of grad school, right? So in terms of insomnia disorder, 10 to 15% report daytime impairment due to the insomnia. So because of that, it's really important to manage this disorder for your patients, because remember, they're working, and you can't really be impaired when you're working. That's not a good thing. So there's two stages of sleep that you need to be aware of in order to really understand the process of the insomnia disorder. The two stages of sleep include non-rapid eye movement, or NREM, and rapid eye movement sleep, or REM sleep. In non-rapid eye movement sleep, most physiological functions are markedly lower than in wakefulness, although there may be episodic involuntary body movements during non-NREM sleep. In contrast, during REM sleep, REM, it's characterized by physiological activity levels similar to those in wakefulness and a high level of brain activity, and is sometimes called paradoxical sleep. Non-rapid eye movement, or NREM sleep, is composed of stages 1 through 4, with stages 3 and 4 being deep sleep. Typically, non-rapid eye movement sleep is punctuated with an REM cycle every 90 to 100 minutes during the night. The first REM period tends to be the shortest, lasting less than 10 minutes. Later REM periods may last 15 to 40 minutes each. But most REM periods occur in the last third of the night. Most stage 4 sleep occurs in the first third of the night. So again, we want to focus on our history when it comes to insomnia disorder to rule out other medical causes and the possible contributors to the insomnia. We also want to consider psychiatric causes and contributors to insomnia, as well as the importance of educating your patient on sleep hygiene strategies. So sleep hygiene strategies, we have to maintain a regular sleep schedule and wake schedule 7 days a week. That's key to getting good sleep, right? Things that would include good sleep hygiene would be eating regular meals every day, developing a relaxing bedtime routine, limiting the amount of liquid consumed in the evening to prevent you from having to get up to go to the bathroom too frequently at night. Same thing with limiting the amount of caffeine consumed later in the day to prevent you from staying awake longer. You want to avoid tobacco and alcohol late in the day because they can stimulate you at times. You want to avoid daytime naps. You want to make sure you're exercising regularly. You want to limit exposure to bright lights in the evening. You want to limit the use of phones while in bed or screens, anything with screens, phones, tablets, computers. The bed should be used for sleeping and sex only. We want to avoid doing other activities in bed that require wakefulness so that the bed is only associated with sleepiness. You're training your brain, right? We want to turn any clocks to face away from the bed to avoid constant checking of time. And we also want to educate that if the patient is not asleep after 20 minutes, that they should get out of bed and engage in a quiet activity such as reading or just something outside of the bedroom before reattempting to fall asleep. Also, guys, meditation, listening to like meditation videos on YouTube, deep breathing exercises. These are also really good things for good sleep hygiene. Okay, restless leg syndrome, another behavioral disorder related to physical and physiological disturbances. RLS is a neurological sensorimotor condition that is typified by uncomfortable sensations in the lower extremities, such as burning, tingling, crawling, itching, and an uncomfortable desire to move the legs with an associated sleep disturbance. The relief of symptoms is usually obtained once the individual moves his or her legs. The diagnosis is based on the DSM-5 criteria, so you want to make sure you refer to them for the complete diagnostic criteria, but symptoms should occur frequently and for a significant duration of time. And like I said before, the symptoms are listed here: an urge to move the legs, uncomfortable sensation, discomfort is only relieved by movement, and the discomfort or urge begins or worsens when at rest, night, or when attempting to fall asleep. The patient and family members need to be reassured and counseled regarding the transient nature of RLS, including the lifestyle measures that can be instituted to assist with sleep. Appropriate sleep hygiene strategies should also be emphasized for restless leg syndrome, and care should be used with all pharmacological therapies because of the possible adverse effects and their potential for drug dependency, especially in our elderly patients. Okay, next we're going to get into our neurodevelopmental disorders, including autism spectrum and intellectual disabilities. Okay, autism spectrum disorder is a neurodevelopmental disorder of childhood that in the diagnostic DSM-5 encompasses the following four former diagnoses, which includes pervasive developmental disorder, autistic disorder, Asperger's syndrome, child disintegrative disorder, and Rett syndrome. Core features for autism spectrum disorder include delays and deficit in social interactions and restricted or repetitive behaviors. ASD can present with or without intellectual disability or language impairment and may be associated with some genetic disorders. The underlying etiology or the cause of autism remains under investigation. There is an apparent role for genetics given the elevated rate of diagnosis in siblings, which is up to 10 times higher than the general population, and the high concordance rate in monozygotic twins. Apparently, 15% of cases of autism are associated with a known genetic mutation. Repeated epidemiological studies have demonstrated no association between the MMR vaccine, which was a big topic of debate in the news for a long time, and subsequent, despite an initial faulty study that suggested otherwise. Environmental factors may contribute to ASD, including closer spacing of pregnancies, advanced parental age, premature birth, low birth weight, and fetal exposure to valproate. Again, when it comes to this disorder on spectrum autism, you want to focus on the history. Okay, you want child on the autistic spectrum, children on the autism spectrum, also often referred to as on the spectrum, have difficulty with imaginary play or sharing, which would be appropriate to their age level. These children may present in primary care with the chief complaint of sameness, such as self-restricted diet and or self-restricted activities, such as lining up cars or watching the fan or toilet spin for hours at a time. Some may spin or twirl, and some may have repetitive movements, such as hand flapping. They are inflexible about routine, become distressed over small changes, and parents might complain about their activities of daily living, such as lack of or difficulty with showering, dressing, or eating. Although there are not exact percentages, most children on the spectrum have difficulty with sleeping and may function with less sleep. They sometimes demonstrate echolalia, which involves repeating words over and over, including those overheard from caretakers. A lot of the times with these children, you will notice that they kind of repeat what you say. Even as they get older and their intellectual ability improves, they will still continually repeat what you're telling them, sort of as a way of processing the way that's just the way they think. They actually think out loud. It's very interesting. People on the autism spectrum, with people with autism, mostly self-talk, which can be misunderstood as a psychotic disorder. Keep in mind, the only reason they're doing that is because they don't know how to process it without saying it out loud. So it's literally like listening to somebody think out loud. That's what it sounds like sometimes when you're around children with autism. Self-talk in public is often due to a lack of social awareness. They are very socially inept at times, and socially awkward. So a lot of their therapy is based around speech therapy, occupational therapy, to kind of help give them better tools and ability to be more appropriate. And not to say that they're trying to take away or fix the disorder, but just give them tools to communicate more effectively. All young children should be screened for the presence of autism spectrum disorders as part of routine developmental assessment. In addition, there are several tools available that can be used to screen for autism in primary care or mental health settings. Some are rated by the clinician and others by the caregivers. So you're going to get a lot of information from your caregivers as well. When it comes to evaluating autism, you're going to want to do a complete physical exam. You definitely want to do a hearing screen, make sure that the issue isn't that the child can't hear. You want to do Woods lamp examinations for signs of tuberous sclerosis. You want to do a lot of genetic testing. They're checking karyotypes, chromosomal microarray, Fragile X testing, and based on this medical evaluation, they will then come up with the diagnosis. They don't diagnose children before the age of 3 because of brain development. And, you know, in terms of diagnosis, if this is something you're even considering as a diagnosis for your patient, you are going to want to get them referred to a pediatric neurologist. These patients, these family members, parents, mothers, they need a tremendous amount of support. There is a lot of resources out there to help these mothers. This is a disorder for life. It doesn't go away. The likelihood is, especially because autism is so closely associated with intellectual disability, the likelihood is, you know, it's very likely that the patient won't be able to live independently as they get older. So a lot of resources need to be put into place. School districts tend to help a lot with this, school nurses, social workers, but you want to make sure that these supports are in place because there is a severe grieving that goes on for these parents because they do realize that their child, you know, it has a disorder that will affect them for the rest of their life. So in terms of intellectual disability, you need to understand the levels of IQ and how it correlates with the level of intellectual disability. So we go from mild to profound. And then in terms of functioning and IQ, this is where we look at IQ and functioning to determine what level of intellectual disability the patient has. Now, this does this can fluctuate, throughout the lifespan, especially as they get resources and education, things can improve for sure. Keep in mind, intellectual disability, the term replaces the outdated term mental retardation. So we used to say mentally retarded, now we say intellectually disabled. It's present when there are deficits in cognition and adaptive functioning. Determining the presence of intellectual disability is important as it assists in the determination of the level of support that someone requires, particularly in school. ID onset must be during the development period, with onset before the age of 18, and has a range of severities. The most common conditions associated with intellectual disabilities are Down syndrome, Fragile X syndrome, fetal alcohol syndrome, as well as autism. Neuropsychological testing must be performed for the appropriate classification. And again, we have classifications of mild, moderate, severe, and profound. When you're evaluating patients with intellectual disability, we're focusing on a complete medical history, including we want to do a 3-generation family history. We want to know who had it, any kind of intellectual disabilities or psychosocial issues throughout the family history. And again, keep in mind, as in 3 generations ago, they may not have had this diagnosis yet, but they still may have exhibited symptoms. Those are things you're going to want to document. Complete physical exam, including assessment for dysmorphic features and neurological examinations. Common comorbid mental illnesses that are associated with intellectual disabilities include attention deficit, depressive disorders, bipolar, anxiety, autism, impulse control disorders, and major neurocognitive disorders. In terms of education to your patients and your parents regarding intellectual disabilities, you want to instruct those families that they should request an educational assessment for qualification for special ed services through the implementation of an IEP. This is something that they will put into place in the child's school. That is a specialized program specifically to help navigate the student or the patient's method of education as they go through their classes. By law, schools are required to conduct an assessment free of charge within a specified amount of time and provide requisite supports and services if the child qualifies. Economic support for these programs varies state by state. Some public schools are better than others in terms of special ed. So something you want to educate parents on is also to really look at their special ed program within their school district, and there's always the option of moving if it's not so great. And that is a thing. In terms of the autism spectrum disorder, how it fluctuates, I wanted to just put this visual guide here so you can understand how one would actually fall on the spectrum and where they fall on the spectrum. So for instance, if the patient is like on the moderate end, they're level 2, they're going to need some substantial support. Level 1 is high functioning autism. They just need a little support, maybe social and communication skills, and repetitive behaviors are noticeable, are only noticeable when they don't have the support with them. So when we get to level 3 and we have severe autism, that's when we're going to need a very substantial amount of support, and basically we'll need full-time assistance every day, In terms of pharmacological management of autism, again, you have to be very, very gentle with this subject, especially with parents of younger children, because they really don't, a lot of them are against putting their child on meds, especially with, the concern of brain development before the age of, 16 years old. Psychotropic medications should be considered when there is comorbid mental illness or if there are specific problematic target symptoms to address, such as severe irritability or aggression, sleep disturbances, or hyperactivity. 2 agents have been approved by the FDA for the treatment of irritability, often manifesting as severe tantrums or aggression, which are risperidone and aripiprazole. Other medications have off-label uses for various target symptoms. If you want to, please look at the drugs commonly prescribed in Table 71.1. Meds should be considered if behavioral interventions were ineffective or if symptoms are severe. Given the communication difficulties of some patients with autism, response to medication may be judged by caregivers. Okay, so when it comes to the medications, you have to keep in mind it's not just about managing the patient's behaviors, it's also about keeping both the patient and their colleagues or their peers safe. For instance, when we have a student, a young middle school student, who doesn't take his medication, and then he goes into the bathroom and lights the toilet paper on fire, this is a problem. This is when we really have to evaluate, okay, yes, this student needs medication, because if he doesn't take it, not only is he a danger to himself, he's a danger to the other students in the school. So these are the kinds of things you have to consider, like how bad are the behaviors, and what is the history of the severity of these behaviors. And that's when we really start to talk to parents and say, hey, this is a problem. They can't be hurting themselves, and they can't be hurting other people. So what are we going to do about it? Because the things we've been doing, the therapies at school and everything else, are not working anymore. That's when you have to really consider medications and start talking about that. Okay, tic disorders and ADHD. A tic is an involuntary muscular contraction or vocalization. Individuals can present with motor or vocal tics, or a combination of the two. Tic disorders often present during childhood, occasionally warrant treatment, and are frequently self-resolve. The most common tic disorder is Tourette's. I'm sure you've all heard of that, characterized by the presence of motor and vocal tics. Behavioral and or pharmacological treatment is warranted when tics interfere with activities or cause undue stress. That's when we want to consider treatment. The average age of onset of tic disorders is about 7 years old, although it can be much earlier. The severity often peaks by 12 years age, and by adulthood, many individuals find that their tics have resolved. Many patients struggle socially and have been shown to have greater psychological distress than their peers, and comorbidities with mental illness is common. So in terms of tics, also keep in mind with autism, it's very, very common to have tics, and they show up very young age. You'll see a lot of flapping in autistic children, especially around the ages of 2 to 3 years old. They start flapping, and even as they get older, the flapping doesn't really go away. It just kind of sometimes diminishes with a lot of therapy, but it still tends to be present. ADHD. Before I get into ADHD, so some common laboratory testing in terms of assessment of tic disorders that you want to definitely order for diagnostics would include a CBC, a blood urea, nitrogen, liver function, thyroid, ferritin levels, and a urine drug screen. Okay, please review the drugs commonly prescribed for tic disorders on table 71.2. Families should be aware that the tics are often transient and self-limiting, and many children and adolescents experience them at some point in their lives. Determining the inciting triggers for tics can be useful for modifying the environment to reduce exposure to these triggers, or developing a management plan for when exposure is inevitable.
It's 8 o'clock.
So in terms of ADHD, attention deficit hyperactivity disorder, the characteristics include persistent patterns in attention, gross motor, hyperactivity, impulsivity, and obviously can interfere with academic, behavioral, cognitive, emotional, and social functioning. It is one of the most common neuropsychiatric disorders of childhood and adolescence, and manifests with these particular characteristics. Emotional dysregulation in adults with ADHD is common, and in some instances, the first diagnosis may not even occur until in adulthood. So your categories of symptoms, remember, include inattention, hyperactivity, and impulsivity. Those are our three main categories of symptoms that are diagnostic criteria to diagnose ADHD. For older children, adolescents, and adults, pharmacotherapy should be considered when symptoms cause clinically significant impairment at home, school, and or work. There is strong evidence for the stimulant medications, given their robust efficacy with response rates of 75 to 80%, and they are considered the first-line pharmacological treatment for ADHD. These include Ritalin and Adderall. In terms of education, you want to make sure you're educating these patients that they have to adhere to the treatment plan, because it'll improve the understanding of the chronic nature. I'm sorry, adherence to the treatment plan is improved when the patient and family understand the chronic nature of ADHD and its potential impact on school, social life, and occupational functioning. So you want to continually educate them about medications and management of side effects, which may improve their adherence to actually taking the meds. I will say, when I worked in the school district and I was had to hand out meds to these students that had ADHD, it's very hard. It's very hard to make them adhere. They get so, and it's not because they don't want to all of the time. I mean, sometimes it's that, because the side effects can be annoying. Many of the students told me about some of the side effects they experience, but more importantly, it's not even just because they forget, or they don't that they don't want to, or they want to avoid the side effects. They just forget. They're so wrapped up in whatever they're doing, they just forget to come in. So I finally just came up with a list of people. I made sure that I double checked that if they hadn't come in, I would call them by a certain time, because I just knew their MO with getting distracted. But I also realized the importance of them taking this medication so they could get through their day. Parents of these patients should be educated regarding realistic expectations and should definitely be made aware of support groups for themselves, as well as child advocate groups. And this goes for also for autism as well as ADHD. There are tons of support groups and child advocate groups that they can definitely get involved with to have help for their child. And in terms of educating them on realistic expectations, you should always encourage these parents to continually advocate for their children, be very involved at the schools, be very much on top of the IEP and the goals that are being established for their children, so that they know what milestones are being met and what they need to do to help also make them met at home as well. What other resources they can additionally add on at home that can help with the academics at school. Okay, next we're going to get into the 15-minute hour. This is basically reviewing practical approaches to doing a really good psychosocial kind of assessment, as well as support within a very short amount of time in primary care. These techniques were developed specifically to help you hone in and really get to the point very quickly, as opposed to thinking you have an hour to do what you don't have an hour to do. Contemporary advanced nursing practice presents many challenges, not the least of which is being on the front lines of health management. Patients present for short office visits with complicated chief complaints, often seeking immediate relief from both physical and mental discomfort. In the real world clinical practice, the distinction between psychiatric and medical illness is often blurry because mental and physical health interconnect. Specifically, psychological problems are often expressed as physical symptoms, and medical problems frequently precipitate psychological distress. Just as medical illness is usually best treated when detected in early stage, early intervention is critical for psychological problems. So in terms of introduction to the 15-minute approach, remember the whole point of this is just to really distinguish between psychiatric and medical illness. So that's why they're really giving you some tools here to use. We want to get early intervention involved as quickly as we can for any psychological problems. We want a call of inclusion of behavioral health specialists on primary care teams. So if we did see that there was a behavioral health issue, we want to know who we're reaching out to give support and advocacy for these patients. The majority of psychiatric symptomology is managed within the primary care setting. So you are on the front lines when it comes to dealing with mental health stuff. So make sure you don't brush it off and you really understand the seriousness of it. Patients reporting psychological concerns definitely happens a lot during primary care visits, as I just said. And it's critical to build psychotherapeutic skills for primary care for providers so you know how to respond to these patients appropriately. So stress is the physical and mental response that results from having to adapt to demands from the external and internal environments. When under stress, people generally cope less effectively than when they feel comfortable or pleasantly challenged. Our understanding of the relationship among stress, coping, and health has been enhanced by the classic long-term studies of Valiant in 1979, whose studies suggest that overwhelmed people regress functionally. Poor adaptation is associated with ill health because of risk of disease increases in those with anxiety, depression, and inadequate stress management. And offering support to those under stress may facilitate their return to adaptive function and health. So social support is a key element in stress management. When one's perception of control over life circumstances decreases, subjective feelings of stress increase dramatically. However, as social support increases, the level of stress decreases. Not surprisingly, it has been shown that poor social support is deleterious to health or detrimental to health. Healthcare providers are in a position to convey essential social support by providing positive feedback to the patient or by suggesting strategies for handling a particular problem. When people are psychologically stressed or medically ill, they may be particularly vulnerable to negative feelings, namely inadequacy and isolation. A key benefit of social support is that it augments a person's sense of competence and of connection. By reminding patients about their basic strengths, clinicians enhance their patients' abilities to function in a healthy way. So here are some common psychotherapeutic techniques that we like. These are the 5 common elements in all schools of psychotherapy. And that would be the expectation of receiving help, participation in a relationship, obtaining external perspective, encouraging corrective experience, and opportunity for patient to test reality repeatedly. Some therapeutic approaches that nurse practitioners are usually positioned to assist their patients in are coping, regardless of the spectrum of the nature of the problem. Skillfully employed, the professional therapeutic persona of the clinician alone can decrease stress, feel less alone, and enable patients to cope more effectively. After discussions with a healthcare provider about their concerns, patients often feel better and may be even able to solve formerly intractable problems. Many clinicians feel more comfortable calling this counseling, but such interactions are essentially considered psychotherapy. Among the elements common to all major schools of psychotherapy are these, as listed here, these 5. And these are the elements that you need to make sure you are putting into all of your therapeutic moments. So the roles of the APRN in terms of expectation of help, the patient believes you will help him or her, so their hope increases. In terms of participating in a therapeutic relationship, the expression of caring and concern is the therapeutic intervention. In terms of obtaining an external perspective, the patient is going to be saying that they're feeling overwhelmed. You're listening and providing external perspective, and the patient feels empowered. A lot of the times in that moment of the perspective piece, you'll start to hear the patient going into this moment of just going on, and you just kind of have to bring them back and say, whoa, 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 let's just come back to the now. Let's just refocus, and you just kind of redirect them to really hone in on what exactly is the issue. And again, this empowers them to get control over their emotions, not become overwhelmed by their emotions, and really direct their energies to empowering them, to motivate them to do whatever needs to be done to get through their situation. Encouraging corrective experience. Here, the patient feels overwhelmed. Again, you listen respectively and provide an external perspective. You definitely put it in perspective, the situation. It's a lot of the times it may seem much worse to the patient than it actually is in reality. You want to encourage corrective experiences, and here you're instigating effective patterns of behavior. So you're just talking about how they could have behaved differently that would have been more positive. Just giving them options as to how they could definitely look at their behavior and say, oh, maybe that wasn't the best behavior. And then repeated reality testing. And here you're noticing small changes at follow-up appointments to change expectations. So we're paying attention to those little changes that these patients are exhibiting, and we're bringing it to the patient's awareness, and then we're documenting it as well to track progress or not track, or to show that the patient is not progressing. Okay, so sorry, I want to make sure. Oh yeah, we got everything. Okay. Next, we're going to go into the techniques used specifically to do this therapeutic conversation. So incorporating appropriate questions and responses regarding a patient's psychosocial situation is an acquired skill. The BATHE technique was developed by Marion Stewart, a psychologist, and Joseph Lieberman, a medical doctor, in their work with medical students, and is elaborated in a full-length book by Stewart and Lieberman, as I put here, the 15-minute hour therapeutic talk in primary care. The big focus in the bathe technique is focusing on the history of the patient. The bathe technique functions as both a quick screening test and an intervention for psychiatric problems, especially appropriate for new patients and those presenting with acute problems and mental distress. It has become an established method of identifying and addressing psychosocial aspects of patients' problems during a brief office visit. It should be used early in the interview, usually after elicitation of the chief complaint and the history of the present illness. The acronym intended to complement the SOAP acronym, Method of Medical Documentation, stands for Background, Affect, Trouble, Handling, and Empathy. And here you can see what these questions focus on. So in terms of bathe would stand for B, stands for background. What's going on? A stands for affect. How does that make you feel? T stands for trouble. What troubles you most about this? H stands for handling. And how are you dealing with this particular problem? And E stands for empathy through reflective responses. And I'm going to go through an example of how this would actually, sound when you act it out with an actual patient. So again, just some more sample questions that can be used when implementing the standard bathe technique: background, affect, troubles, handling, and empathy. Although bathe is not the only technique a clinician can employ, it brings order and efficiency to what may otherwise become a muddled and time-consuming attempt at a psychosocial assessment. Again, bathe just helps direct the conversation, guys, because again, when people are in crisis and they're having a moment of just craziness or psychosocial decline, they get all wrapped up in it. They go on and on and on. No, you got to shut it down. You don't have time. You want to get to the point and you want to really try to come up with a plan. So using this technique is very, very helpful. In the process, it also helps the biomedical model to the psychosocial model in a way that is meaningful for both the clinician and the patient. By asking pointed, focused questions that lend themselves to brief but comprehensive answers, the clinician is able to incorporate this necessary form of assessment into a format that enhances rapport and also helps the patient express feelings, gain insight into the meaning of the situation, and become empowered. Most significantly, it satisfies all the aforementioned elements of psychotherapy. Bathe provides the expectation of help, a therapeutic relationship, an external perspective, the encouragement of new behavior, and the ongoing opportunity to test reality. The clinician must exercise discipline, however, and refrain from a lengthy exploration of the patient's life. Okay, we're not here to fix everybody's life here. We're just here to fix the problem at hand so the patient can continue on with life. All right, and we are not the end all answer all to everything, but we can help them get through a moment for sure. And we also want to just make sure that it's not causing them enough severe, depression or anything to the point where they're considering suicide as well. Okay, again, a part of the bathe technique also keeps the patient, helps maintain ownership. That the patient needs to take responsibility for dealing with their psychosocial behaviors or issues. Bathe helps the practitioner, assess the patient and pinpoint the problem, as well as empowers the patient. Again, it's crucial that the practitioner does not own the patient's problem. There's nothing that you did or could have done to help or prevent whatever the patient is complaining about. You want to make sure the patient realizes they've created this problem. It's their problem. It's their job to fix this problem, and we're here to help them. What we're there to do is develop a better understanding of the situation and the effect it's having on the patient, and then allow the patient to own the problem and then come up with a solution together to help fix the problem. And the therapeutic part to the relationship is that the patient now is confident that you are supportive and able to help. The benefits and of bathe, again, is useful for promotion, prevention, intervention, and diagnosis of treatment. Great screening tool. Please make sure you know the acronym and what each one stands for and appropriate questions, because that will be on both your quizzes, exams, and your boards. So there's the emergence of the positive bathe, okay, and that includes best, affect, thankfulness, happen, and empathy. Again, it's an emergent of a positive psychology. We're just trying to promote positivity and positive vibes, positive energy. We're focusing on virtues, character strengths, and benefits of happiness and personal growth. Literature links positive affect with health and longevity. It bolsters the immune system, and research findings show like people who have undergone this technique of positive psychology, they're just filled with gratitude and show improvement. And again, if I'll show you on the next slide, it focuses on autonomy and oh, I'm sorry. It focuses on autonomy, personal accomplishment, thankfulness, and general positive affect. So again, here's some more questions to give you guides as to how you would approach things, like in terms of best. When we're considering positivity, we're thinking about best. What's the best thing that happened to you this week? Or A, affect. How did that make you feel? Or T, thankfulness. What are you most grateful for? Or H, how can you make things like that happen more frequently? And empowerment. I believe that you can do that. Okay, these are therapeutic ways to communicate with your patient, guys. Again, all of these motivational techniques can be used to address a wide variety of issues, including all of these listed: substance abuse, weight loss, lifestyle changes, health promotion, any of them. All of these can, promote positivity in all of these areas. So remember the principles of motivational interviewing. Can definitely promote ambivalence in some of these patients because change is hard. Change and growth are difficult, and people definitely are resistant to it. You will find, especially with any kind of neurodevelopmental issues, specifically with autism, you're going to get a lot of ambivalence, in that area of in that disorder. They are very routine oriented, structured. Any kind of change would definitely produce ambivalence, but you have to kind of work through that, because if you don't, there will be no change, and then things will not get better. And how do you do this? Address the ambivalence. You explore internal motivation, values, and goals. Focus on some goals for these patients. What do they want? Where do they want to achieve? Where do they want to go? Motivational interviewing also involves respect for the patient's autonomy and the belief that the patient is the expert on his or her own behavior, because they are. You don't know what they know. You don't know what they've gone through. You can't judge them. You just have to listen empathetically and establish a non-judgmental, non-confrontational approach, because you have no idea what this patient has been through. Despite what they may have told you, there may be a lot more to the picture that you don't even know. More little techniques for motivational interviewing. Keep in mind, motivational interviewing involves the empathetic listening and establishing the non-judgmental, non-confrontational approach, as I just mentioned. You want to encourage change talk. That's what you want. And motivational interviewing is a way of being with a client and not just a set of techniques for doing counseling. Techniques of MI include the open-ended questions, offering affirmative and supportive statements, reflectively listening, and summarizing the patient's situation. MI also encourages clients to request permission before offering advice or intervention. So you always want to ask them, is it okay if I offer you some support, some tips for support, or some suggestions? Are you okay with that? I have some thoughts and some ideas on some interventions and some advice that I think you might benefit from. Would you like to hear it? Or is it okay if I share it with you? Unsolicited advice is likely to promote resistance and more ambivalence. So you have to be careful. If a patient is not yet ready to change a behavior, like beginning a diet, monitoring their glucose, adopting an exercise routine, decreasing substance abuse, all that stuff, it is unlikely that the client's advice will be well received. So again, you just ask for permission. The 4 principles of motivational interviewing use the acronym RULE. Okay, so the 4 principles use the acronym RULE, which stands for resisting the writing reflex. Understand your patient's motivation. Resist the writing reflex. What does that mean, guys? That means you're going to resist the temptation to always think everything you say is right, like everything you're saying is right. That's not what we're doing here. We are understanding our patient's motivation, we're listening to our patient, and we're empowering our patient. An important tenet of MI is to use the use of reflective listening, a key component in helping patients explore ambivalence and resistance to change. Like, we want our patients to figure out why, for themselves, why they're ambivalent and resistant to change. Reflective listening ranges from simple to complex, repeating, rephrasing, paraphrasing, and reflective feeling. Dialogue is strategic. Clinicians should guide the conversation with reflective statements, not questions, and accept the patient regardless of his or her own readiness to change. This is encapsulated in the approaches of open-ended responses, affirmations, reflective listening, and summarization. The acronym OARS highlights these four important components. So we have O for open-ended responses, A for affirming patients, R for reflective listening, and S for summarizing to the patient. The last part of MI is to ask the patient's permission to help him or her pursue a particular course of action. The accompanying nurse situations present examples of applying OARS to patient interviewing. So here we go, guys. Here's a clinical situation. Let's put this into clinical perspective. So here we have a patient, Martin. He's a 33-year-old man with a history of heavy alcohol abuse. He presents to his provider and reports a recent job loss due to excessive tardiness. He reports concern that his family faces eviction for failure to pay rent, and then he discloses that much of his tardiness was a result of hangovers from all of his drinking. He has voiced concerns in the past, specifically reporting, "My wife nags me about spending too much time with my drinking buddies." Martin expresses concern that an intense substance abuse program will be time-consuming, but reports several unsuccessful efforts to remain sober using the 12-step program Alcoholics Anonymous, or AA. Martin says, "I know I can really drink a lot after work. It relaxes me. The job thing is tough. My wife pressures me to get treatment. I tried AA, but it didn't work. A friend of mine did some intensive thing, but I don't have time for that. How can I spend 8 hours at some treatment facility when I need to be out looking for a job?" And everything this patient is saying is very it makes sense. It's very realistic to real life, because you have to remember, we have all these protocols and we have all these programs and all these support things and all this diagnostics and all these things we have written in our books and textbooks, but life doesn't work that way, and patients are not robots. You know what I mean? Every human being is different and everybody has different goals and expectations, so you got to work with people, right? So what are we going to do for this guy? So how can the APRN respond appropriately and effectively to Martin? So first, let's start with our open-ended responses. What's this been like for you, Martin? What's the most important thing to you at this point, Martin? Martin, it can be incredibly difficult to acknowledge these things. The fact that you are here today and talking with me about it shows a commitment to making things better. I'm proud of you. That's affirming the patient. And now reflective listening. So Martin, the drinking is causing a strain, but it's a way for you to relax. And it sounds like, Martin, you want me to find a program that is right for you. Okay. And now summarizing for the patient. Okay, Martin, for our last few visits, I know that you've been thinking about cutting back on the drinking. It seems like today, after the job loss, you are more concerned than you were at our previous visits. You are thinking about treatment options, but it's important for you to find a program that is going to fit your lifestyle. Does this sound correct to you? And then next, we ask permission. Do you want any information about alternative treatments in the area? Or can I give you some alternative options to find, some resources? Are you interested in that? And let him take from there. These are ways you can incorporate all of these techniques into your motivational interviewing. It's just about talking to people and being gentle. Here's a summary table. I wanted to include this of the different counseling strategies that we've talked about. Pretty much all of these. We did the BAVE, we did motivational interviewing. We did talk about all of these different feedback about personal risk. And of course, we talked about the 5 A's. This is specifically, we talked about this for smoking cessation. All right, in summary, remember, psychological and physical health are related. We want to use our bathing interventions to screen these patients, and then use motivational interviewing to help these patients improve and come up with a plan for change. Remember, primary care visits are critical in addressing patients' psychological well-being and assisting patients with desired lifestyle changes. We are at the front lines, guys, so really make sure you understand how to communicate with these patients to get them the best help they can get. All right. Next week, I will be posting the final exam study guide on Wednesday, so look out for that. I'll make an announcement on Wednesday once it's posted. I will be posting as well as, and of course, wrap up and review PowerPoint to go with the study guide. It will not be Wednesday, but it will be by the end of the week. Next week's review for the module will be urgent care visit and specialty exams. Your readings include chapter 72 through 75 and chapter 76. And then, of course, like I said, we'll do the end of course wrap up and review, as well as we're going to make sure you do complete your course and clinical evaluations. All right, guys, hopefully this was helpful. I will be posting the quiz reviews as well for musculoskeletal and psychosocial 1 and 2. All right, and definitely use those quizzes as reviews for the midterm as well. And I'll definitely put all the quizzes reviews within the module so that you can have quick and easy access to them to use them for review. Hope you have a great week, everybody. If you have any questions or you wanted to meet with me, please feel free to email me. My schedule is crazy, but I will definitely make it work if you guys needed to meet with me. Have a great weekend. Thanks, guys.